Welcome to Hopkinton Drug's third annual Health and Wellness Lecture Series. My name is Caroline Wood, and I will be facilitating this evening. It is with great pleasure that all of us at Hopkinton Drug are able to bring this free series as a service to the community in coordination with the volunteer efforts of such prominent medical professionals. Now, without any further ado, I'd like to introduce Dr. Patricia J. She is a board-certified obstetrician and gynecologist. Dr. J graduated from Boston College and UMass Medical School. Dr. J currently practices functional medicine, gynecology, in addition to bioidentical hormone replacement therapy at Visions Healthcare in both Wellesley and Dedham. Please join me in welcoming Dr. J.
Good evening, everyone. Well, you came out in the snow. It's been such a wonderful winter, hasn't it? And it seems like it'll never quit. We're going to be here in July, and it's still going to be snowing, I think. But anyway, it's great that everyone has come out here tonight. Okay, so this talk is about bioidentical hormones in menopause. And I'll just start by talking a little bit about the physiology and the basic science of the hormones, just so that you'll know what I'm talking about later on in the topic. And we'll kind of cover what happens with menopause, what women go through, although I think probably most of you probably already know that. The history, a brief history of hormone use, and then the differences between the conventional hormones and the bioidentical hormones, pros and cons, and then kind of how we put it all together, and then lots of time, hopefully, for questions and answers at the end. Is the sound okay now? Are we? Okay. All right, so here's just a quick review. Okay. These are the players in the symphony. We've got a whole bunch of hormones that have a synchronized. We've got 3 different locations that are making hormones. We've got a center in the brain called the hypothalamus. It's on the undersurface of the brain, and it's just above where the pituitary gland is connected to the brain by a little stalk. And then, of course, the ovaries, which we all know are making the estrogen and the progesterone. So, but the hypothalamus makes releasing hormones. It tells the pituitary what to do. The pituitary then releases stimulating hormones that go in the bloodstream and travel to the ovaries through the bloodstream. But if you make note that it all starts in the brain. And this is just a schematic of a normal menstrual cycle, just so you can appreciate the complexity of it. The notice on the third box down, this is what's happening in the ovary. The egg, which we as females are born with millions of eggs in our ovaries. At puberty, the cells that surround the egg start responding to the stimulatory hormones and start the menstrual cycles. And so those are the cells in the growing follicle. Those are the cells that make first estrogen for the first half of the cycle and then progesterone in the second half of the cycle. Oh, I found it. Okay. Estradiol, of course, that seems to be this one right here. So this is day 1 of the cycle, and that's day 28 when the period comes. So first it's just estrogen, then it's estrogen and progesterone together, and that makes the lining of the uterus grow up quite thick and be a good place for implantation. And then these are the pituitary hormones, FSH, follicle stimulating hormone, and LH, luteinizing hormone. And it's via this surge here in the LH that the ovary gets the signal that it's time to make an egg and ovulate. So the only reason I'm mentioning this is we started talking about puberty, but when we're talking about the other end of it, when the eggs have actually start to become depleted, so there aren't as many eggs left in the ovary that are actually responsive to these hormones, they get to be a bit lazy. And then the pituitary has to respond by ramping up, usually first the FSH, the follicle stimulating hormone, to try to get the ovary to keep ovulating. And so this is one of the blood tests that your primary care doctor or your gynecologist may measure to determine if you're near to menopause. But unfortunately, it's not very precise. As you can see, at least one day in the cycle, it varies quite a bit from day to day. You know, so that's really, this one is, I think, well, I think this one is that's the LH and this is the FSH, but it varies quite a bit from day to day. But as you get closer to your menopause, those levels start to creep up. But it still is not too precise. So anyway, I think that was important to let you know. And so as the FSH gets elevated, it does actually get the ovary to produce more estrogen initially. So as the ovary's trying to ovulate, it makes more estrogen, but then it may not do a very good job of making very much progesterone here at the very end. And so that's why in early perimenopause, which is the 10 years that precedes the last period, women can feel really out of balance because their estrogen may be higher than it's supposed to be and their progesterone may be lower than it's supposed to be. And that can make women feel very uncomfortable. That's responsible for that PMS feeling, that feeling like you really want to tear someone's face off, but you can't. The bloating, the breast tenderness, the headaches with the periods, the heavier periods, all of those things are responsible for, are caused by the estrogen being too high initially and then the progesterone being too low. And then as you go into the later phase of perimenopause and the periods start to space out or skip, then the estrogen levels actually start getting lower. And then what you feel when your estrogen levels get lower is more of the hot flashes and the trouble sleeping and just kind of that exhausted feeling that you can get. So, and then the testosterone, the male hormone, which is made in a woman both by the ovary and by the adrenal gland, or adrenal glands. They're two very small glands that are located right above the kidneys, and the adrenals make a lot of different hormones for the body. But the adrenals also have the ability to make all of the sex hormones, testosterone, estrogen, and progesterone. And in fact, women who have very healthy adrenals, which maybe fewer and fewer of us do because of all of the stress in our current lifestyle and our current society and the way we have to live our lives, our adrenals are challenged. So our adrenals may not be doing so well, but if we have healthy adrenals, that's kind of like your safety net that will make those hormones that the ovary has stopped making. But the testosterone varies quite a bit. For some women, the adrenals make most of it, and other women, the ovaries make most of it. So that can vary quite a bit from woman to woman. So what happens when we're going through menopause? How do we feel? Okay, so this is what I just told you. So this is, now I put symptoms in the quotations there because the word symptom connotates that it's a disease, okay? And it's really not a disease, is it? It's just, it shouldn't be a disease. It's a natural process that hopefully if we live long enough, we're going to all go through. So symptoms kind of already puts it out there as if there's something wrong, you know, that going through menopause is a sickness. And I certainly, whenever I teach the medical students, I always try to make sure that I emphasize to them that they should not look at it as a disease. You know, a disease that needs to be treated, that it needs to be replaced, you know, because many women actually can go through this process and, you know, as quite a a drastic change in the hormones. They can do it quite successfully without being treated. But many women do feel pretty crummy as they're going through it, and these are the things that can happen. The hot flashes, I like to refer to them as power surges. Sometimes I'm oftentimes asked, particularly by the students, well, what is it physiologically that makes a woman have a hot flash? And it's caused initially back in that little center in the brain called the hypothalamus, again, that I told you about. And as it's trying to get that ovulation, get those hormone levels up again, it's sending out these little pulses of its releasing hormone. And at that particular time in a woman's life, it doesn't work to produce the hormones, and it can have some effects on the rest of the body. And what it'll do is it'll cause the arterioles just under the skin to dilate, to open right up. And so the skin feels very warm, and it gets red, of course, because there's an increased blood flow in that area. Doesn't actually, if you were to take your temperature during a hot flash, you don't actually, your core temperature is not elevated. But your surface temperature, if somebody touches you on the shoulder, then they can sometimes even through your clothes, they can go, wow, you are hot. And you have the feeling that you have just stepped into an oven or something. So sometimes some women do describe it as the heat's coming from inside, but some also, feel like it's coming from the outside or from the surface. And then there's a reflex that the skin has when the temperature increases, and that's a sweating reflex. So it all generally lasts maybe about 5 minutes, maybe less, not always accompanied by a sweat, but it certainly can be. And so that's how when women will ask me, well, I don't know for sure if I'm having a hot flash, and we describe it, well, does this feeling leave you, after 5 minutes or so? If not, then it's probably not a hot flash. But women still do also, nonetheless, may notice that they just feel warmer all the time. And everyone has a kind of a different sensation from it. I've had women that don't notice the hot part of the hot flash. They only notice the sweats, and they call it a cold flash. And they get they get a chill once the hot flash part is over. And then I've had women that have described instead, they don't feel the hot or the chill at all, but when though blood vessels in the skin dilate, it makes the heart have to work a little bit harder to keep the blood flowing to all the vital parts of the body. And they notice their heart rate speeds up a little bit, and they will get, it's even palpitations. I always tell the students that that's a good differential when they're in the emergency room and somebody comes in and they say they keep having this faint feeling, and they get that 10 times a day. This is actually one of the things that can cause that. So it really varies quite a bit from woman to woman. So the sleep disturbances, they can be related to the sweats and the feeling hot, and sometimes they're not. They're just simply, boom, you're awake. And why are you awake? You don't know why you're awake, but you are. And then that makes you mad, and so you don't want to go back to sleep because you're mad. But after you've stopped noticing, if you've gotten used to it, many women can just say, okay, I'll throw off the covers, and then they'll drift back to sleep until they get cold, and then they'll put the covers back on, and it's just a real show. Okay, the other thing that I wanted to mention was the painful intercourse. That usually happens in the later phases of menopause, more when the period's been gone for a while. And that's due to the vaginal tissues getting thinner and more easily traumatized and inflamed. It's not really exactly dryness, although everyone always calls it dryness. If it was just dryness, then the moisturizer would work for that, or the lubricant would work. But in many cases, the tissue is so thin, there can even be bleeding. It just can be very difficult. But fortunately, that's very easily treated by just applying a little topical estrogen, which that can be put on without the hormones going through the whole body. So, and it only needs to be used maybe once or twice a week. So that is one of the easiest things to fix without as much to do as the hormones that go all through our system. Okay, the joint pain is also something that can happen, and that's something that can confuse your primary care sometimes. It's more pairs of joints, you know, elbows, wrists, something like that. And it's not accompanied by any swelling or redness or, you know, like arthritis. It's just that the joints are sore. And it does respond to hormone treatment. But it also, all of these things, the good news is that all of them tend to get better with time, even if you don't do anything about them. But there are lots of things you can do about them. But if you weren't able to do anything, most of these things would get better. The joint pain does, the hot flashes, the night sweats do. Now, the low libido is very multifactorial. Part of it is certainly due to the fact that it may be painful to have intercourse, and who's going to feel like doing it when it hurts? But it also can be from that minority of women whose male hormone level drops when they go through menopause as well. But the majority of women, the low libido is really more of a either a body image or how the woman feels about herself. I love to quote Dr. Christian Northrup, who's like my idol about women's health and menopause, and she says that the biggest sex organ in the body is the brain. And so this is a time of change, and oftentimes some women do feel that it's symbolic. Unfortunately, our society doesn't particularly value maturity, and so it means to some women that they're going to become old and ugly and cast off from society, and who feels very desirable when they're thinking about themselves in that way. So but it's really, Dr. Northrup and I love to remind women of what a wonderful time it is. There's a lot of positives to it. It's a time when there's a lot of liberation. You know, you don't necessarily have to worry about, you know, what you're doing and what people think of you, because, you know what, you're just menopausal anyway. So just you can speak your truth. You can say what you feel. You can do all the things you really wanted to do. And that's very, very important. This kind of, I'll digress here, that culturally, as I said, you know, it doesn't seem to be a great place to be in our society. But there are other societies, like, for example, certain Muslim societies in which they throw a huge party for women when they go through menopause. And that's because their particular religion prohibits women who are menstruating from worshiping and participating in parts of their cultural things when they're menstruating. So when you stop menstruating, that puts you on an equal, you know, at least to some minor degree, on an equal footing with men. And so they throw a party. They think it's a great time. And of course, in a lot of our Asian cultures, you know, wisdom and maturity are valued much more than they are in our society. So I always try to remind people of that. The weight gain that can occur, that tends to be more early on in the perimenopause, and that's due to that elevated estrogen can actually work, as Dr. Blanchard will agree, that it works against the thyroid hormone. So even though your thyroid hormone levels might be all right, the estrogen is you know, preventing it from keeping the metabolism going, so it can slow the metabolism down. And again, that's temporary. And sometimes when we restore the balance with the progesterone, that weight gain can be reversed. Let's see, the growth of facial hair. Now that is one, again, that's much later on, and that is something that's almost universal. It happens to almost all women, and that's also very, very hard to reverse. So I oftentimes will say to women, you know, one thing that you're not complaining of is that the other places where you used to remove your hair is not so much growing there anymore. So it's just kind of, you just have to change your removal patterns from one place to another. And when I say that, most women are going to say, yeah, you're right. Yeah. So, okay, urinary urgency. That is something that, again, is kind of an estrogen thing, and oftentimes using some estrogen vaginally, which will actually get it to the bladder, can correct that. But most of the time, it's more a combination of the lack of estrogen and then the caffeine that many of us do take in on a regular basis. We just tend to be more sensitive to it once our estrogen levels drop down. And so I can point out to a lot of women that if they reduce their caffeine intake, that will help their urinary urgency. Okay, so we'll go on to the next one. Quick history of hormone therapy. I'm interested in history, so I always like to put this in. Originally, back before 1950 or so, all of our hormones came from animal sources because they didn't have any ability to synthesize them in the laboratory. So they came from pork or cow sources, and they were injectable because they weren't absorbed from the GI tract. And then in the 1960s, a pharmaceutical company came out with their product Premarin, which they derived an actual pill that could be absorbed from the GI tract. And Premarin was derived from pregnant mare's urine, and it was a combination of 5 different horse estrogens. There was the pharmaceutical company sponsored a gynecologist named Dr. Robert Wilson to write a book about his practice in prescribing Premarin to women and the miracles that it would work for women who, of course, didn't have any hormone replacement to take at that point. This was the new thing, and of course, it made a lot of them feel much better. And he wrote this book called Feminine Forever, and it really did the job for the pharmaceutical company. It caused a lot of people to be interested in taking this. But unfortunately, they found after the first 8 years of using Premarin that Premarin by itself would increase a woman's risk of getting uterine cancer by a factor of 5 to 8 times. So 800% increase in uterine cancer. So that kind of started the pendulum swinging. So first hormones are good and then they're bad. So that was the beginning. And then in the 80s, actually probably a little earlier than that, but they added, they learned how to make a synthetic form of progesterone called Progestin. Progestin is like the group of the synthetic progesterones. And if they gave both of them together, that did eliminate that increased risk of uterine cancer. So that was a relief. That was when I first started to, I was in residency and in early practice at that time, and we had a really, really complicated regime that we would have women, they'd take their Premarin from the 1st to the 25th day of the month, and then they'd start their Provera on the 15th and take it for 10 days, and then they'd take nothing from the 25th, and then they'd usually get a period because the doses were pretty high. And so you can, I'm sure, predict that there's not that many women that are willing to do that complicated of a treatment, and plus get your period back. They really question, is it really worth it? And maybe it's not. So, but that's what we had at that point. And then they did come out with a combination where the Premarin and the Provera were together in one pill. This is the same pharmaceutical company. And they really gained momentum at that point. There were some studies that suggested that women who took hormones lived longer than women who didn't, and that it was because of a decreased risk in cardiovascular disease. So there were a lot of studies that were done that were trying to prove this, but unfortunately there were a lot of conflicting results on the studies, and they weren't long enough of duration, and they didn't have enough women in them. And so the pharmaceutical company then said, okay, well, we're going to really put a lot of money into this, and we're going to nail the market, we're going to have a goal of every woman in the United States is going to be taking hormones to prevent cardiovascular disease. So they partnered with the National Institute of Health, and they started this study called the Women's Health Initiative. And they recruited thousands and thousands of women. They had 16,000 women who they gave this, either a sugar pill or the Prempro to, and then they had 11,000 women who had already had a hysterectomy, and so they didn't need the progestin part to prevent uterine cancer, so they could just take the Premarin by itself. And they were planning on doing this study for 10 years. They started it in '95, and then they discovered in 2002 that they couldn't continue the study any further because it was doing exactly what they were hoping it was not going to do. It increased the risk of heart disease, and it increased the risk of breast cancer by a very, very small amount. But still, they did not want to be responsible for any study women, to be getting breast cancer or dying of a heart attack. So they stopped the study early, and I'll never forget that summer because their information came out in a journal article that the press got hold of before the journal came to our offices. So everyone had this information before we did without any details, and of course it caused a panic, and here went the pendulum back again, so it was good again and now it's bad again. And it was a very hot summer with a lot of calls to the office of women panicked and stopping their hormones because it was going to be bad for them, and I'll never forget that. So what happened, bioidentical hormones had actually been around for a long, prior to that, but a lot of us got interested in them at that point. At that point, I said, okay, I'm sick of this pendulum. I want to get off the merry-go-round. There's got to be something else that's safer, that's not so controversial. And so actually my patients and Dennis at Hopkinton Drug suggested to me that I learn more about bioidentical hormones, so he invited me to go to a conference on it. And as soon as I learned about it, I said, oh, this is great. I've really got to, I've got to really offer this to my patients. So that was when I got started on it, about 10, 11 years ago now. So now, to just give you a brief idea of what the differences are between, definitions. Our conventional hormones would be your Prempro, for example. These ones right here, Premarin, Prempro, Premphase, Activella, Femheart. There's another one now, Meno. I can't remember because I never prescribed them. And then the topical ones, the patches, are Astroderm and Clemara, and they contain estrogen only. These first ones contain both the progestin and the estrogen. And the synthetic progestins by themselves are Provera and Agestin. And Agestin is the same progestin that is in some birth control pills. That was another great idea that somebody at a pharmaceutical company had. They said, oh, this is great, we're going to put the estrogen together with the progestins that are in the birth control pills, and then we'll put it in a package that looks like birth control pills. So women will feel like they're young again when they're taking their birth control pills, right? They'll do anything they can. But I always tell people that, this is a good thing because these hormones are taken by millions, if not trillions, of women in birth control pills. So they're proven to be safe, and they're proven to be effective in keeping you from having irregular bleeding, but still not the way I would prefer to get my hormones. But here are the points on the conventional hormones. So what was that? Did I do something wrong? Okay, I'll try not to do whatever I did. They're synthetic, or they come from horse's urine. They are marketed by pharmaceutical companies, but but they can be gotten by a regular prescription from your regular primary care doctor or your gynecologist. You can get them at your local non-Hopkins and Drug pharmacy, and you can get them at Hopkins and Drug too. They are covered by insurance. Did I say that already? And then you can get them also in the mail order pharmacies and things like that. So they're relatively easy to get. Although just getting your prescription at Hopkins and Drug is relatively easy as well. But they may come from an animal source, and the synthetic progestins have some unwanted effects that people may not want. They can have a little more of the male hormone effects of the hair growth problem or acne or things like that. They can also cause more bloating. And then the really unwanted effects is they also, combined with the estrogen, are responsible for the increased risk of blood clots that can form in the legs and travel to the lungs, the heart attacks, the strokes, and things like that. So some of the risks do come from the synthetic progestins. So that's kind of the deal with those. The bioidentical hormones, by contrast, they come from a plant source, and they look exactly like human hormones. So our hormones, the three estrogens, the estradiol, the estriol, and the estrone, and then, of course, progesterone and testosterone. And then we've even got an adrenal hormone that's a male hormone precursor called DHEA, and that can be made as a bioidentical hormone preparation. So they are naturally occurring substances according to the FDA. So legally, they cannot be patented. So this is part of the reason why it's so weird that these things aren't, you can't get them by a regular prescription and your insurance doesn't cover them. Or the insurance doesn't cover as well. Some of the insurances do, but insurances that are looking for excuses not to cover drugs will say, oh, well, it's not recognized by the FDA. And that's because it's a naturally occurring substance. So if it can't be patented, then a pharmaceutical company can't make money off of it. So it doesn't get advertised like the other conventional hormones do. And that kind of explains why it's a little bit hard to find information about it. You have to watch Oprah or go to Hopkins and Drug. It's oftentimes your gynecologist on the corner, doesn't have the information about them, unfortunately. And I didn't before I went out and got myself educated about them. They tend to have a gentle and predictable effect, and they can take longer to work than the conventional hormones. But I mean, that's also good as far as side effects go. They have much fewer side effects unless you've overdosed somebody. They can have the same side effects if your dosage is too high. But the way I prescribe them, I always start at the lowest, a very, very low dose, and then I work my way up with that, because that's what I was always taught is the right thing to do. Because if you start out too high, then you can really be kind of chasing your tail as to, well, the tricky thing is that some of the side effects of it being, the dose being too high is the same as the dose being too low, which is hot flashes. So it can be a little bit tricky to know where you are. Should you raise the dose? Should you lower the dose if you start it too high? And then the way we get these hormones is they are formulated by a compounding pharmacist, most commonly in a cream form. And I believe that the cream form is best because the female hormones, they're steroid hormones. They're in a family, a class of steroid hormones. That means they're fat soluble. So they are readily absorbed right through the skin, right into the tissues just beneath the skin, and they're actually stored there, they're deposited there. And then the body can actually draw on them as it needs them, which is in contrast. If you're using this cream as a daily dose, you've got that steady supply. But if you put a patch on, it does go more quickly into the bloodstream, and you get a very high peak, and then it drops off, and you've got to put on another patch before it drops off too much. You end up with a lower total dose if you use the cream on a daily basis. Sometimes also we use progesterone in a capsule form or a pill form, and there is a pharmaceutical product of progesterone. It's called Prometrium down there at the bottom. It only comes in 2 strengths, though, unfortunately, and not so much. The lowest one is usually higher than what I usually will give to women, so that's unfortunate. But and the testosterone and the DHEA can be put into the cream as well. So that's the thing on that. So as I kind of already had mentioned the pros and cons, the conventionals tend to be more covered by insurance, although even the insurance companies are reluctant to cover even the conventional forms of estrogen. It's like they're prejudiced against women or something. I don't know if anyone else gets that impression. But the generic forms of these preparations, there are very few, and they're only estradiol, and they don't necessarily, they come in few strengths. The patches are huge and have a lot of side effects. But those are the ones that are the only ones, the generic ones, as you know, that your insurance will give you that nice low copayment of like $15 or whatever. If it's a brand name, which most of them are, you're still paying, $50 for your copayment. And then if you have to take an estrogen and a progesterone, that doubles it. Even the conventional ones aren't covered well by the insurance company, unless you've got a really good insurance company. And like I said, you can get them at any pharmacy, and the doctors are familiar with them. But the dosages are limited, so you really can't, it's very hard to fine-tune that dose to what the patient needs. And then, of course, there's that risk of heart attack and breast cancer and stroke, particularly with the pill forms of the conventional hormones. The estrogens, as they're going, if they go through your gastrointestinal tract, they go directly to your liver first before they go to the rest of your body. And the liver is responsible for making those lipids, the fats in the blood that your primary care measures to predict your risk of heart disease. So estrogens can affect that. It can raise the triglycerides. It can raise the good cholesterol, the HDL, but it doesn't equate to a lower risk of heart disease, unfortunately. And then the other thing that the liver does is it makes clotting factors. And the estrogen going full force into the liver can increase the risk, increase the clotting factors and increase clotting in the body, and that can be a risk of stroke or the blood clot in the legs that form. So that's kind of not so great. The bioidenticals, we talked about insurance coverage. They most of the time have to come from a compounding pharmacy. They're slower acting, as I mentioned. The dosing is much more flexible. If you're using a cream and you get it in a little syringe and we ask you to put on 0.5 mLs a day, if you call me and tell me that there's, it's either not enough or too much, I can say, oh, just put on 0.4 mLs. You don't have to go get a new prescription. You can just use a little more or a little less of the cream. It's very flexible. It's much safer as far as the risks go. I just found out about a very large study that was done in France with over 22,000 women that used different forms of estrogen, but they compared the risk of breast cancer. And they found that the natural estrogen and progesterone had a much lower risk of breast cancer in the women that used it there compared to the other hormone preparations that they used over there, which actually are none of the ones that we have here. It's more natural. It's more physiologic. And of course it comes from plant sources, so they're sustainable. So that's the pros and cons. So, putting it all together, are bioidentical hormones right for you? That's what women come in and ask me every day. And what I'll do is I'll first take a very careful history and ask women all kinds of personal questions, trying to get an idea of her day-to-day life and how much this is really affecting her, because that's really important. And then, are there any other histories that are important? You know, does the woman herself have breast cancer, or does she have a sister and a mother and a grandmother that had breast cancer? Things like that, heart disease. And then we do an exam, or if someone has already had an exam with their own doctor, that'll suffice. Make sure they've had their mammogram or some other breast imaging study. Ultrasound can be helpful sometimes in cases of bleeding, you know, when there's bleeding that we're not sure is normal or not. And then as far as the testing goes, I don't always go do testing, but most times I do, because I do want to just confirm that the woman does indeed have the hormone levels that I think she does. In where I am now at Visions, I do blood tests and saliva tests. My previous position when I was at Southborough Medical, we had Quest Lab, and that lab was not good at doing hormone testing. The results never correlated very well with what my patients were experiencing. So I did almost exclusively saliva testing in that scenario. And as a purist, the saliva testing is the best way to measure hormones. And the reason is because, as I mentioned in the beginning of the talk, the hormone levels fluctuate quite a bit from day to day or even hour to hour. And if you measure it in the saliva, it's gives you more of a long-term idea of what the hormone's been doing over the last day or few days, 24 hours usually. And on one sample, you can also, besides measuring the sex hormones, you can measure cortisol, which is the big player adrenal hormone. So I can get an idea of how a woman's adrenal hormones how their adrenals are working, as well as what the sex hormones are doing. It's much harder to get a good cortisol level in the blood because it's very high in the morning and very low in the evening, and it also is released in a burst when there's anything that gets someone nervous or afraid, and I don't think everybody walks into the lab to have their blood drawn in a totally relaxed state. In fact, some people don't like having a needle in their arm at all, and so that's going to spike your cortisol level up too, so it's not all that accurate. But the saliva is a little bit more cumbersome to do. You take home a kit, and you spit into the tube, and then you send the sample off to a lab that's all the way out in Oregon, and it takes a little longer to get the results. But it's a better result and is worth doing. So then after I get results, or even sometimes before I get the results, if it seems pretty clear cut, we will really talk about that risk-benefit ratio. What are the downsides versus what are the upsides? We talk about just the nuisance of having to go and get a prescription every month at the pharmacy. And then I will oftentimes discuss what some of the other things that women can do besides hormones, if she hasn't tried them yet. We talk about lifestyle changes. We talk about diet and herbal supplements. And we talk about common triggers for hot flashes, and unfortunately, that evening glass of wine is one of the biggies, and a little hard to give up sometimes, but that can really, for many, can cause those night sweats. And hot drinks, spicy food, and then of course anything that gets you kind of nervous, can trigger a hot flash. And just being in a warm place can do that as well. And then also understanding what to expect, the reassurance of, well, this isn't going to be, forever, hopefully. A few rare women that does happen, but for the most part, it does tend to get better with time anyway. Sometimes just that reassurance is very, very helpful. But then if the woman is truly miserable, she's tried a lot of other things, and there's no contraindication to it, then we can go ahead and prescribe it. And then I monitor it by having the patient call me and let me know after month by month how she's doing with it. I make an adjustment. And then when we get to the point where she says to me, "Oh, Dr. J, this is great. I feel wonderful. I feel like I did, 5 years ago or whatever," then I know that's her dose that she should be on. And we continue that for a while. And then hopefully what will happen after another couple of years maybe, or even less, is we try to drop the dose back a little bit. Because in my view, this is as I said, a normal life process, and I believe that the role of these hormones is just to help the women through the process. Hopefully the end point is that her adrenals get healthy enough to support her, her body adjusts to the new level of hormones, and she doesn't have to continue to be on them forever. There are other opinions about that. Certainly if anyone's read any of the Suzanne Summers books, the point of view there is that it's kind of the anti-aging point of view, that we should have our hormones that we had when we were 20 for the rest of our lives to prevent the diseases of aging. And so the doctors that ascribe to that theory are going to use much higher doses, and they're not going to have people wean off of it. So just so you understand that. So that's basically what I do. And this is my locations where I am presently. I'm in the Wellesley office most of the time, and 1 day a week in the brand new Dedham office, which is very nice. Our website is very informative, visionsmedical.com. I'm going to have my business cards at the back if anybody wants to pick them up. And before we